we are going to discuss today on some of the recent questions. So this was the question number 1, which is what is the type of the knot shown below? Now, what kind of knot is this? What will be your answer? So it is typically a square knot. So there is no difference of opinion in our thought process. The answer will be. So if you could look into the picture which I have shown, probably this could help in the upcoming exam or for learning also. Now, if you could see this picture, now you'll be definitely able to make out. This is a granny knot, and you can see the difference. It consists of 2 throws. Crossing does not occur in any throw. It's a blinding knot and not secured knot, and tendency to slip when subjected to increasing pressure inferior to reef knot. And this is the typical knot which is asked in the question. The reef knot, the square knot, consists of 2 rows. Crossing is done in each throw, and it's a square knot performed for tissues that are not under tension. Okay, so this is what is about the reef knot or the square knot which has been asked in the question. It's very, very clear. And rest of the knots, the types of knots I have loaded for the purpose and for the time to discuss all the 40 questions. I will load this immediately tomorrow in the app so that you can go through the rest of the knots. So overhand knot, figure of 8 bend, and all those half knot, all these are for your purpose for learn further. A patient had a drug eluting stent placed recently. Elective surgery can be done after. First, fix the question. You say yes or no. So once the question and options are right, then probably we'll go into the answers. Okay, fine. If the question is right, yes, all of you agree. Now you tell me what's an answer. What is the answer that you will opt for this? Yes, excellent. The right answer is 6 months. 6 months. Elective non-cardiac surgery after drug eluting stent implantation may be considered after 180 days. If the risk is further delay is greater than expected risk of ischemia or stent thrombosis. Based on 2014 AACC and AHA guidelines, timing of elective non-cardiac surgery in patients with previous PCI is as follows. Elective non-cardiac surgery should be delayed 14 days after balloon angioplasty and 30 days after bare metal stent implantation. So elective non-cardiac surgery should not be performed within 30 days after bare metallic stent implantation and within 12 months after drug eluting implantation in patients whom dual antiplate therapy will not be discontinued preoperatively. Subsystem 20th edition, page number 212. So this question is directly from Subsystem, and so the best answer here will be 6 months. Now you can see this question. Spinal cord stab injury with the ipsilateral loss of touch, vibration and proprioception, contralateral loss of pain and temperature is seen. This question we discussed in the class, and the same question has been discussed in the class, and it's a very direct, simple, straightforward question. Whether we have discussed or not, this answer is simple. Answer is, this is a Brown-Sequard syndrome. Yes, it's a straightforward question. So all of you would have answered right. So next slide. So caused by the functional hemisection of the cord, damage to the dorsal column pathway, ipsilateral loss of discriminative touch, vibration, proprioception below the level of the lesion. So ventrolateral spinothalamic tract acid crosses. So there will be a contralateral loss of pain and temperature. Yes, sensation beginning 1 or 2 segments below the lesion. So even we have discussed the pathways, and this question is a standard repeat in exams, and also it has been discussed. Again, the same what we discussed is given in the flow chart. Next slide. See the picture. Ipsilateral loss of the touch, vibration, and contralateral loss of pain and temperature. And dissociative sensory loss could be asked is also a typical question in case of syringomyelia. Now, this is a typical repeat, the same to same. This has been discussed in a chapter of general surgery in subcutaneous lesions in Bailey and Love. And congenital blue-gray nevus on lower back regress by 7 years of age. What could be the answer? So these are the question and options given to me. Yes. Yes, the right answer is Mongolian spot. Excellent. Mongolian spot is the right answer. So Mongolian spot is a congenital blue-gray macule found on the sacral skin. Pigmentation initially deepens and regresses completely by the age of 7 years. Okay, so the other types which I have given in the explanation for your purpose to read further. So tricholemoma is a congenital hematoma with an appearance of linear verrucous nevus, 10% form a BCC lifelong nevus of sebaceous of Jadasons. Okay, maximum chance. So this class is meant to discuss all the answers with the questions. So this is not a teaching class. This definitely is to solve the questions. So that's the reason why I am just focusing only on the answers. Maximum chances to turn invasive in which type of DCIS? Yes? Yes, all of you are right. The answer is solid. Comido and solid has a maximum chances of turning into invasive. More than 50% of comido and solid can turn into an invasive ductal carcinoma from DCIS. Okay, the stuff cribriform, pleomorphic, all this again a repeat. This is a straight repeat from what we have discussed from Bailey and Law. Next slide. And the same thing is given in Subiston and Schwartz. There is no difference here. Next slide. So treatment for patients with bulcogonoma, necrolytic migratory erythema. Simple, straightforward question. What would be your answer? So basically the diagnosis is bulcogonoma presenting with the necrolytic migratory erythema because these patients are more prone for hypoaminoacidemia. Understand this? Hypoaminoacidemia, and they're also prone for thromboembolic manifestations. So because of hypoaminoacidemia and thromboembolic manifestation, administration of amino acids has a role in patients with necrolytic migratory erythema. So the right answer for this question will be option C, IV amino acids. So treatment begins with a medical therapy to improve the patient's nutritional status with supplemental enteral nutrition in excess of basic caloric needs. Octreotide is often required for congestion with an enteral nutrition, and intravenous infusion of amino acids may be required. Yes, may be required. Next slide. So it's a direct take question from Subiston. Gene involved, it's a simple question. Gene involved, discussed already, gene involved in MEN2A. What is the gene involved in MEN2A? All of you. It's a favorite topic for our discussion. Excellent. All of you. What's an answer? All of you? Hello. Are we all connected? Are you all there? Yes. Yes, it's a red proto-oncogene and it's in chromosome pericentromic region of chromosome number 10. And red ligand is identified as a glial cell line derived neurotropic factor, encodes for cytokine tyrosine kinase receptor. Point mutation will lead to medullary cancer. Rearrangement will cause papillary cancer. So routine part of our discussion. Yes? Yes. Answer is red proto-oncogene. Click please. Answer please. So the same thing is given and it's universal. It's nothing in a specific book and it can be in Subiston, Bailey and Schwartz. Next slide. Cleft palate, retrognathia and glossoptosis is seen in. Yes? All of you? The answer is Perry-Robin syndrome. Option A is the right answer. It's a typical question. It's a typical question and it's a straightforward question. There is no difficulty here. Perry-Robin sequence is comprises of isolated cleft palate, retrognathia, posteriorly displaced tongue, glossoptosis, which is associated with early respiratory and feeding difficulties. Excellent. Next slide. Next slide. Bailey and Lau, 27th edition. I will tell you this is 100%. This is 100. This question was ideally discussed. I mean, it was straight discussion on this. Yes, word to word the same question was there in Bailey and Lau we discussed. I don't know how many of you remember this, but this question is there in our PowerPoint slides in uploads in Bailey and Lau. Do you remember this? Do you remember PSA commonly associated prostatic cancer? Could anyone recollect during the exam? Hello? Were you able to recollect this question during the exam? So these are some of the questions are very satisfying, very, very satisfying. I mean, real benefit for our kind of hard work and discussion that you've been doing for 3 months. Yes. So the right answer is, all of you, the right answer is Pro PSA. Pro PSA was an answer. Next slide. And this is typical question from Bayesian law. It's a typical straightforward question taken from word to word from Bayesian law. There's nothing else. Okay. So the same explanation what we discussed earlier is almost repeated here. And the question, the explanation took straightly from them. And the same data given in Campbell also, it is doubly confirmed. The answer is Pro PSA. Again, you should have remembered this question with the picture. We discussed this Bose-Noy classification for multiple thickened septa and calcification with independent enhancement. What will be your answer? Yes. What will be your answer? All of you? Excellent. Excellent option. Answer is D, type 4. This is a straight question from Bayesian law with picture. I want you to recollect this picture when we discuss this. Yes, you need to recollect this picture. Yes, independent of the cyst wall, calcification, maximal thickening, high risk of malignancy, type 4. Yes, type 1, type 2, type 2F, type 3, and type 4. Bailey page number 1390, 27th edition. Yes. And this was discussed almost twice. Yes. And it's a straightforward question. Yes, this is also has been discussed in the class about DTPA scan, DMSA scan, the best test for renal scarring diagnosis, architectural distortion, yes, contraction, anatomical abnormalities, everything is DMSA scan, dimercaptosuccinic acid scan, and we also discussed DTPA scan, diethylene triamine pentacetic acid scan, and we said it's about the GFR, measurement of GFR is neither secreted or absorbed from the renal, yes, and it's in a glomerular filtrate and gives you the exact measure of GFR, functioning of GFR, functional aspect of the kidney, and we also been discussed about the radioisotope scanning technique. We also discussed about the hydronephrosis, furosemide challenge. Hope you remember the answer is DMSA scan, option B. So I cannot see a paper easier than this. Next slide. 54-year-old lady presented with a breast lump of 3 into 3 centimeter, which shows haphazardous cylindrical cells. Haphazard cylindrical cells. The diagnosis is. All of you, what would be your answer? So the answer for this question would be tubular carcinoma. Excellent. Now tubular carcinoma, another type of ER positive HER2 negative cancer. Next slide. Almost always detected on mammography in small irregular masses. Tumor cells are arranged in well-formed tubules, have low-grade nuclei, haphazard array of small randomly arranged tubular elements. This haphazardly array of randomly arranged tubular elements, the word to word given in subsystem, 20th edition, 840 page number. This is a repeat question from what we discussed. And this question is directly repeat from the class. And the same question has been asked. Flap with warmer and turgid on post-op rounds causes. Yes, it's a venous compromise. Answer is B, option B. Hope you remember this tabular column. Go back, this is from straight from Bayesian law. This question we have discussed with the table. Warm, redness, arterial compromise will be pale. Arterial compromise will be pale. If there is a change in question, if it is redness, then it could more go in favor of venous compromise only. And you can see the color. This question on a flap with a warmer, turgid on post-op rounds. Infection, the flap will not be turgid. It can be thickened and edematus and not be turgid. And rather it will not be warm also. Next slide. I feel the answer strongly goes in favor of venous compromise. If the question and options are right, my preference would be for venous compromise, but looking at the face value of the question. Go back to the question. Is the question and options are right, but something added to the question can go in favor of any of those options. You just fix this question and answer. Is this question exactly the same and options are same? If the question and options are same, the best answer would be Venus compromise. This question has already been discussed. This is already available. This question is already available with the tabular column in our in our PDF. Whatever the question that has been based out of Bailey, 100% all we have covered. That is available in our PPT in the notes. Next slide. Loss of venous flow results in a blue congestion, increasingly turgor, rapidly capillary refill, and initially warm flap. Bailey, page number 646. Next slide. Yes. Type 4 muscle flap. Again discussed. This is discussed question. This is discussed question. Types of muscle flap. You should see, go to the chapter on plastic surgery today itself. You'll see all those questions that we have covered in plastic surgery sessions. Right answer will be? All of you? This is sartorius. So type 1, go back. This same table we have discussed from Bailey. It is also available in Subiston and Swatch also. Type 1, single pedicle gastrocnemius, tensor fascia lata. Type 2, dominant pedicle with minor pedicles gracilis and trapezius. Type 3, dual dominant pedicle gluteus maximus, serratus anterior. Type 4, segmental pedicle sartorius and tibialis anterior. Type 5, dominant pedicle with secondary segmental pedicles. That is Smith's dorsi. Next slide. Patient had a splenic trauma. Very much a repeat question. Very much a repeat question. We had a lot of discussion on this splenic artery aneurysms and splenic rupture, splenic trauma. He is a stable subcapsular hematoma and a pseudoaneurysm. Management is all of you. The answer is angioembolization. The reason being, if there is no pseudoaneurysm, then probably this patient would have gone for observation. Because of this pseudoaneurysm, there could be a feeding and there should be a bleeding. So that's the reason why we need to do an angioembolization. Yes, angioembolization will be the appropriate answer. And this scale of grading of splenic injury has been well discussed in the class. I'm not going into that details. So the answer will be angioembolization. Next slide. The use of splenic angiography and embolization represents most recent advances in evaluation and management of splenic injuries, commonly centers with angiography to evaluate, often to treat stable patients who demonstrate an active extravasation. So the best way to use splenic angiography is still being elucidated, but it has become almost uniformly used in some capacity in at most centers. One major benefit of angiography is the potential to obstruct the sites of bleeding endovascularly by angioembolization. Next slide. The same is given in Bailey also. There's no difference between both of those. Again, this question in Southampton, this again we have discussed in the class. Erythema around the sutures is seen in which type of Southampton grade? Answer should be, we will go to the classification. I have the table with me. Yes, yes. When you look into the table, Southampton table, and it is in Bailey and Love, the same we have discussed, page number 48. Now, this is the grading. You would have seen 1 normal healing with mild bruising or erythema, 1A is some bruising, 1B is considerable bruising, 1C is mild erythema, 2 erythema plus other signs of inflammation, 2A at 1 point, 1B around sutures, 1C along the wound, 2C along the wound and 2D around the wound. Now you tell me what was the question asked. If the same question was not asked, then definitely we can fit into this on our table, whatever, because we have the entire table with us from Bailey and Love. What was the question asked? If this is not the question, what was the question asked? Erythema around the wound. If it is an erythema around the wound, then the answer will be 2C. This is erythema around the suture. Was this question asked or was around the wound was asked? You will definitely know that based on this classification, around the wound, then the answer will be 2C. Around the suture, it will be 2B. So according to the question, the option will vary. Okay, medullary thyroid cancer. In a singer, the best treatment would be whether the singer or not a singer, we know. And it's a straightforward question only. So it is, the answer is universal, the answer is direct. It is a total thyroidectomy with a central neck node dissection. We know that medullary thyroid cancer has high propensity to involve the pretracheal lymph nodes, and the treatment of choice is total thyroidectomy, central neck node dissection. Simple, straightforward question that has been discussed in the class. Next slide. Nothing much to discuss here. Cancer lip drains into which lymph node? Yes, all of you? So we know that level 1 will be, yes, submental, submandibular, level 2 upper jugular, level 3 middle jugular, level 4 lower jugular. So the cancer lip will definitely drain into 1, 2 and 3. So they're the primary lymphatic drainage. Of course, skip metastases are seen, but the question is direct, so it is not asked about skip metastasis. So answer will be A, option A. Technetium-99 scan is useful in parotid for what? Again, a simple straightforward question. Discussed question. And we discussed in the concept of what? This was not directly discussed. What we discussed is the tumor. Answer is option D. Orthan's tumor will show hotspot of technetium-99 scan because of increased oncocytes. So oncocytes has an uptake of technetium-99, it can show hotspots. So that's how this question was discussed, and definitely it is an easy question to answer. Option is answer D. You can see that oncocytoma also shows hotspot on technetium-99 scan on Orthan's tumor. This occurs due to high mitochondrial content. Oncocyte-rich Orthan tumor, oncocytoma, both incorporate technetium-99, appears to a hotspot. This was discussed. Unresectable oral cavity, cancer oral cavity is involvement of tooth socket, pterygoid involvement, maxillary involvement, skin involvement. See, option B looks likely, but you should also know what are the other unresectable areas. Now, pharyngobasilar fascia resectable, deep to constrictor muscle is a natural barrier for from the invasion into the prevertebral fascia, which is unresectable. Best option would be pterygoid involvement. T4B is considered as unresectable. Inoperability, metastasis is different from unresectability. So this was reference taken from Submission 20th edition, page number 793. So the best option would be option B. Next slide. Now, this is a repeat question, and CT, emphysematous, pyelonephritis, RBC and WBC in urine, and the same picture we have discussed in the class. What will be the answer? And this is a straightforward question. We discussed acute pyelonephritis, we discussed chronic pyelonephritis, xanthogranulomatosis pyelonephritis, emphysematous pyelonephritis. We would have discussed that in the exam, in the class. So the answer is emphysematous pyelonephritis. There's no doubt about it. We also discussed more commonly seen in diabetes mellitus and in the parenchyma of the kidney. Yes, the most common being E. coli, gas-producing organism. Bailey and Love, 27th edition, page number 1404. Same picture available in PPT. 60-year-old male, ulcer on the cheek with white edges and central depression. What is the diagnosis and how will you diagnose? Pearly black sheen is a type of BCC. The most common type of BCC is nodulo-ulcerative. You know this? And we also discussed peripheral palisading. Types of BCC we discussed. Types of BCC. It is also called rodent. Yes. So the right answer will be BCC with edge biopsy. With an edge biopsy. Head injury. We discussed in trauma, head injury, trauma, neurosurgery. 25-year-old lady presented with a headache and following finding is imaging. What will be the best treatment? You can see the CT scan. I don't know whether the same picture or a similar picture given in your exam. Yes. What will you do? What will be your answers? What answer is the best answer among the options given? Next step was asked, not the best was asked. Okay. So what will be the next step? So if it's going to be the next step, then what will be your next step? Okay, let it be a next step. Next most appropriate management. What will be the next most appropriate management? You see a gross midline shift. You see that there is a gross midline shift. You just need to tell me, is this kind of a same picture is given? Is a kind of a similar picture given? Okay. No midline shift is seen in the exam. Okay. Okay. If there is no gross midline shift, not like this, if there is no gross midline shift, only compression of the lateral ventricles. Okay. Then go to the options. The next management will be anti-edema measures. You'll go for mannitol and intubation. Mannitol and intubation, if there is no massive midline shift, compression of lateral ventricle will regress. Once you go for anti-edema measures. If it doesn't regress and GCS still drops further, then you will prepare the patient for craniotomy. IV mannitol will be the next step. It is not the management of choice. There is a difference. You have told me two different things in the question. One is about the next step and the other is about the best management. Here the question says best management is craniotomy. But the next step will have to be ventilation, mannitol. Ventilation, mannitol, I'll just repeat this. Ventilation and prepare the patient for intervention. Yes, this has to be the line of treatment. The next would be anti-edema measures and prepare the patient for craniotomy. The best management is craniotomy, no doubt about it. Best management is craniotomy. If they ask you, the next step is anti-edema measures. Is it clear? If it's going to be the next step, it is to be mannitol. If it is going to be the best management of choice is craniotomy. So that is the difference. So this question is already there in Bailey and Love in our PowerPoint also. PowerPoint slides in app, so you can go through it later. Next slide. Yeah. 5-year-old child with inguinoscrotal swelling since birth can't get above the swelling, translumination positive. Swelling increases in the evening and testis is not separable, separately palpable. True statement would be. So communication with the peritoneal cavity, this looks like a congenital hydrocele. Congenital hydrocele and congenital treatment for congenital hydrocele and congenital hernia are the same, herniatomy. Do you have any difference of opinion? Is it okay? The answer is comfortable? Okay, gunshot wound on the right upper quadrant, right flank on the laparotomy, bile leak and fat necrosis seen. Next step. The answer is Cocker's maneuver. What do you mean by partial Cocker's and complete Cocker's? See, Cockerization is the mobilization of the duodenum, right? Yes, if you could mobilize up to the IVC, it is partial. If you could expose the aorta, IVC and aorta, it is called complete Cockerization. That will allow you to maneuver better, allow you to maneuver the duodenum better. That's the definition. Next slide. Infant with wrinkled and lax abdomen along with dysplastic hip. Which of the following is true regarding this condition? The standard entrance exam question. Correct. The option is Eagle-Barrett syndrome. Option is option A. So prune belly syndrome or Eagle-Barrett syndrome, both are same. Prune belly syndrome refers to a disorder that is characterized by extremely. Next slide. Stop here. Don't do anything. Prune belly syndrome refers to a disorder. It's given in page number 1743 in Schwartz. Refers to a disorder that is characterized by extremely lax lower abdominal musculature, dilated urinary tract including bladder and bilateral undescended testis. True prune belly syndrome appropriately describes the wrinkled appearance of the anterior abdominal wall that is characterized seen in these patients. Prune belly syndrome is also known as Eagle-Barrett syndrome as well as triad of syndrome because of the three major manifestations. 27th question, patient with the fever, jaundice for 7 days, history of passage of worms with the stools many times in the past, ultrasound shows a long CBD stricture with CBD 9 centimeter and 9 millimeter in diameter and proximal dilatation. Which of the following is true regarding this condition? It's a straight question, easy and the simple question discussed. The answer is caused by ingestion of snail. Chronic sinuses. This is a typical of chronic sinuses. The reasons for the stricture was not there. Worms in CBD will go for ascariasis, no doubt about it. You know why linear shadows are seen in CBD? If there are linear shadows seen in CBD, that means what? Why it will go in favor of ascariasis? Or somebody was answering that. Why? Because why? Can anyone explain that? Worms. So why you are getting that shadow? It's because when you give a contrast, the worm will also swallow the contrast. If it's ascariasis, the worm will also swallow the contrast, and the contrast will be seen inside the intestine of the worm. That's the reason why you get a linear shadow. You understand? I mean, I don't know the question what was asked, but I'm just telling you, if a linear shadow or a tram track appearance is seen in the CBD, that will go strongly in favor of ascariasis. It's a typical question for ascariasis. Was that in this line? Was this question an answer? Was this in this line? Was the line of question in this area, if what we are discussing? Then that means this option should also be different, and the answer should also be different. No ERCP. Then how it was diagnosed? How a linear shadow seen in what? Linear shadow seen in what? Seen in an IV contrast or PTC? How it was seen? So, I mean, you need to fix up the question and answers. So this is the line of discussion. If this is the question, snail will be the answer. If this is not, if ascariasis will be asked, linear shadow will go in favor of ascariasis. I just leave it to you. I just leave it to you at this point to just make those corrections accordingly. Most common cancer risk due to immunosuppression. This we have discussed, man. This is a straightforward question. This we have discussed in transplant also. Yes, the straight question we discussed. So when stricture was not given the question, only linear shadow was given in the question. Okay, then the management could be ERCP and sphincterotomy. I mean, what we can go for here. In even the options do not fix that. No, you can manage medically by giving antihelminthics. Yes. And allow that to come out automatically. If not, you have to do ERCP and pull out. No ERCP. Then the management could be medical management can be an appropriate answer here. Medical management could be an appropriate answer. Provided if there is no stricture in CBD as given in the question, only linear shadow is seen in imaging, and then it could be medical management. Dead worms will not take linear shadow. Dead worms do not take linear shadow. Understand this. Only active worms have linear shadows. Facial nerve identification. This was well discussed in the class, and this we wrote the course of facial nerve. Hope you remember in the classes. One of the classes that we discussed the entire course of facial nerve. So anyway, the answer is straightforward. The answer is option B. Both in the master class and also in Bailey based class, this question is there. It is a tragal pointer. This is also called tragal pointer. This is approximately 1 centimeter anterior to the tragus, median anterior to tragus. This is for the location of facial nerve trunk. This is the location for facial nerve trunk. Straightforward question. And we also discussed about retrograde dissection of facial nerve. Retrograde dissection of facial nerve is done through which branch? All of you? Most preferred branch for retrograde dissection of facial nerve is correct, buccal branch. Buccal branch is what we use for retrograde dissection of facial nerve. Excellent. Next slide. Bailey and Love, page number same as been discussed earlier. Page number 790. Next slide. Most common indication for liver transplant. This also been discussed in transplant chapter. Yes, the right answer is, and we also discussed what is an absolute contraindication. In the same context we discussed, before we discussed indication, I asked you in the class, what is an absolute contraindication for liver transplantation? You remember this question during our discussion? Just before indication, I asked you about what is absolute contraindication. You all answered right. What you answered? Can you recollect? Can you recollect this class? What is the absolute contraindication for liver transplant? 3 points we discussed in context to this. I'm repeating the same question. Correct. Ongoing substance abuse. Excellent. Ongoing substance abuse. And we also discussed age is not a limitation for liver transplantation. You remember this? And the most important match. What is the most important match for liver transplantation? Yes, size. Size was the most important match. Yes, these are the lines. Next slide. I will just show you the tabular column. Next slide. Same table available in Subsistent, Bailey and Schwartz. Only the numbers are slightly different, but the preferred numbers are the same. Indication for liver transplantation in adults, and in adults will be non-cholestatic cirrhosis of viral hepatitis B or C. Yes, alcoholic and cryptogenic. This is the number one. When you go in children, it is biliary atresia. There is no biliary atresia here. So let us not worry about adult or children here. So I feel the answer is option A. If the question and options are right. The questions and options are right, the answer will be A. Most frequent site of A ganglionosis of Hirschsprung disease. So the Hirschsprung disease, this is definite. Which one is the indication? Again, the answer remains the same only, no? Answer remains the same. So most frequent size of an A ganglionosis. Most preferred site for liver transplantation, most preferred, or for A ganglionosis? Anyway, the right answer will be rectosigmoid. Whatever might be the type of question, preferred site or frequent site, rectosigmoid is the most common. The discussion was at length and breadth of this, and we have discussed all the types of Hirschsprung disease, the method of diagnosis, everything was in detail, and this is straightforward question you would have answered right. 100% I'm sure. Photo image of 2-month baby with a birthmark and stain on the cheek. Stain on the neck, occipital area, right side of temporal area, medial to the ear, mostly like diagnosis. If these options and questions are right, the right answer will be option A. Answer will be hemangioma. Answer will be hemangioma. Next slide. Bailey, page number 613. Capillary hemangioma, strawberry nevus, commonest birthmark occurring most commonly in head and neck. 90% appears at birth. As a consequence of intravascular thrombosis, fibrosis and mast cell infiltration, 10% resolve each subsequent year, with 70% resolved by 7 years old. White skin affected most commonly, and girls are affected 3 times more than boys. And the same explanation with questions are asked now, is there in a PowerPoint slides also in Bayesian law. Still the answer remains hemangioma only. There is no difference. This again we have discussed in the class. Solomon patch we discussed, capillary vascular malformation we discussed in the class. Next slide. Yes, 32-year-old male operated case seminoma 7 years back, went to the bike accident, then evaluation of traumatic extradural hematoma was done. On postoperative day 4, he presented with an apneic test positive, pupils dilated fixed, BP 120/80, GCS 3/15. This was a last before class on transplantation. About the methodology for brain dead individuals, diagnosis of brain dead individuals. This question was discussed from Bayesian law. What is the answer here? Next slide. So apnea was first. So let me go to the explanation and read the facts. So accordingly, you will change your answer. Next slide. So again, this was discussed. This is available in our PowerPoint slides. Please go back to our class in Bailey based. You will have the details of that. Anyway, I have placed some details here in page number 364 under the chapter of transplantation. Next slide. So the factors determining the organ function after transplantation, the donor characteristics of extreme of age, presence of pre-existing damage, hemodynamic and metabolic instability, procurement related factors of warm ischemic time, type of preservation solution, cold ischemic time. You remember this? The optimum time for cold ischemia is the lowest for, we've been discussing about small intestine and heart. We had a discussion, I made a mistake in that. Yes, safe maximum and optimum. I don't know how many of you remember this area when we discussed just before the exam, 2 or 3 days before the exam. Yes. And recipient related factors, hard work never go waste. That's what I was telling you during the class also. Okay. Recipient related factors, technical factors relating to implantation and hemodynamic stability, immunological factors, presence of drugs to impair the transplant function. Next slide. Patients with RTA, warm extremities, most likely cause of this condition. RTA, warm extremity. So it will be definitely, the answer will be a neurogenic shock. A neurogenic shock. If these options and to the questions are right, the answer will be spinal cord injury. The answer will be spinal cord injury, option B. Neurogenic shock presents with hypotension with a normal heart rate or bradycardia and warm peripheries. This is due to unopposed vagal tone resulting from a cervical spinal cord injury at or above the level of sympathetic outflow. And it should be treated with an inotropic support and care should be taken to avoid fluid overload. Okay. This presents with hypotension, normal heart rate, bradycardia with warm peripheries. The question is warm peripheries. Go back. Comfortable with this answer? Shall I move? Okay. Next slide, please. Next slide. Next slide. A photo of this kind of a photo was given. I don't know whether this kind of photo was given or not. These options were there. Then it looks like a ectopic pregnancy. Ectopic pregnancy. Next slide. Tubal pregnancy, ectopic tubal pregnancy. Yes, next slide. It's given in Bailey page number 1518. It's a bluish appearing mass cyst within the right fallopian tube and there was a whitish appearing ovary away from the mass seen laterally depicting the clearly something within the fallopian tube. So this is given in Bailey and Love only. Next slide. Image of a chest X-ray showing a central venous line with the left pneumothorax. I mean, I don't get the complete question options. And from what I have learned from students who have written the exam, I had to frame this question for me. I just put for the discussion here. Was a kind of a question asked like this with an X-ray, image of a chest X-ray. There was no question like this. Okay, then leave it. We'll go to the next question. Tension pneumothorax comes separately, not now. I have a question for that. Okay, if no question is asked, leave it there. Now read this question. 54-year-old, I have a question on tension pneumothorax. We'll finish this and come back to this. 54-year-old premenopausal lady with a history of part B of Euro, okay. 54-year-old perimenopausal lady with a history of breast cancer, T3, N0, M0 with an MRM 10 years ago. She was ERBR positive, HER2 negative, treated with hormonal therapy, now come with recurrence. What is the next step? Was the question and options right? Fix the question and answer, please. Yes. Now what is the right answer? What is the probable answer? The probable answer will be, yes, the right answer is biopsy. You will do a biopsy and assess the ERPR status. Local recurrence, again, the answer remains the same. There is no difference. Because earlier this patient was ERPR positive and this patient still continues. Now, before you do a local excision, again a biopsy should be done. That is my opinion. And when you do a biopsy, it is better to assess the receptor status to proceed further. Whether to go in the line of surgery again. I feel biopsy will be a better option here rather than go straight for a local excision of the tumor. Is it okay? Yes. A young patient brought to the emergency department the road traffic accident with a raised JVP, dysphonia, no breathing sounds, breath sounds on right side of the chest. Immediate treatment would be. Hope you remember this. We have been discussing about the triangle of safety, insertion of chest tube, and I was discussing with you about the various scenarios of chest tube insertion, the experiences in the emergencies. Yes. So it's a straightforward question. We already discussed this in depth. So it is a needle, wide bore needle in the second intercostal space towards the chest, towards the apex. Yes. Blade inside the lung. Yes. Blade sucked into the lung and milk in the ICD tube. Remember all the stories? Yes. Stories we remember. Of course, yes. Fantastic days. 3 months. 3 months. Thoroughly enjoyed to discuss various chapters. I find no difference between that class and this class today. You tell me what kind of difference is there? Nothing. Nothing. No difference. Answer is option C. Answer C. Next slide. Bailey 367. We have all discussed this in length. I'm not going into those details. Next slide. Next slide. This picture was shown to you. Yes. This triangle of safety we discussed. Indications for tube thoracotomy. Okay. Next slide. Hyperthyroidism. You remember hyperthyroidism in pregnancy. We discussed. I do remember the drug of choice. Yes. Before going to the question, you tell me what is the drug of choice for pregnancy? Hyperthyroidism in pregnancy because of Graves. Most common is Graves. Most common cause of hyperthyroidism is Graves. Drug of choice in Graves is because, what is the answer? Propylthiouracil. Why we give propylthiouracil? Remember? We give propylthiouracil because it crosses the placenta, does not cross the placenta. You remember the stories we discussed? It has to be always given with low dose thyroxine. Antithyroid drug. See, he has given all antithyroid drugs is contraindicated. It's a wrong statement. Radioactive ablation can be given absolute contraindication. You remember this? The absolute contraindication for radioactive iodine ablation is pregnancy and children, and with eye signs. People with eye signs. Yes. Beta blockers are contraindicated. No, beta blockers are there to control the symptoms, sympathetic symptoms. Yes, of all the 3 options are wrong. So only the answer is surgery in second trimester can be done. Yes, only that option is available best for here. Best. Among this option given, if the question and answer remains correct, appeared, the answer will be B. Answer will be B. Option is B. Answer is B. Yes. Answer please. And you remember in Graves' disease, when we will do total thyroidectomy and when we do subtotal thyroidectomy. Patient without eye signs. You remember this? Patient without eye signs. Only you do subtotal. With eye signs, you should do total. You go back to the classes. If required, just for revision, go back. Probably it may not be required for all of you because of the reasons that you would have all done well. I am sure when the results come day after tomorrow, each and every one of you will get the specialty of choice. Everyone will get. I have no doubt about it. I don't want you to go back and see any PowerPoint slides. Relax. 25th, you have your day. Next slide. This also discussed in breast cancer pathology. Eczematous lesion of the nipple. Image of the breast. No nipple areola appreciably. Only scaling is there. It was mentioned 3 centimeter palpable lump present in the areolar area. Probably it was mentioned Paget's. Which of the following is true? What will be your answer if the question and options are right? This is the 40th question. Pages was not mentioned. Okay, fine. The destruction of the entire nipple and areola, the eczematous lesion of the nipple and areolar complex. Histology will show the various forms of T-pex. That means its diagnosis is Paget's. And we also discussed subareolar palpable mass seen in 50% of cases, serosanguinous discharge, cracked nipple, T-pex in histopathology, differential diagnosis malignant melanoma. You remember? And it's an external marker of internal ductal neoplasm. Yes, the difference between eczema and Paget's is eczema is always bilateral, Paget's is always unilateral. This was what we discussed in the class. Exactly the same question. There's no change and it is very easy and straightforward. The answer is option D.